my slides are mostly geared for the US centers. So there are some statements I can't take it literally here. I'm going to point out those things. So when to consider is, we have already talked about that there has to be a reversible cardiopulmonary disease. That's number one there. So, and there has to be a significant amount of conventional mortality should be high enough, but also echo mortality should be low. So that should be there. What is this number? It's a moving target. If you take all the criteria are 90s criteria here, what we see in the books, and then in the modern day with a different conventional management, our mortality has actually come down significantly in all our ICUs. So, and then also more and more people are comfortable with doing ECMO. Okay, now we're doing a rare conditions which are relatively contraindicated. So my kind of suggestion for the new centers, or basically centers for India, is lethal malformations. No, don't do this here. Anything we are doing cardiac surgery in twice a week 18th. We have done it as two because family wanted to do it. We don't want to do it here. We talked about that. Just the A gradient is for the sea level. Hyderabad, you know what is the altitude? It's 540 meters. It's at the best time, it's about 715 millimeter mercury barometric pressure instead of Miami at 760. So your A gradient may be about 580, but you're considering ECMO on this patient. Okay, think about that. Now, OI. This is, I think, where I think the other day going high in the OI, but it's the other way around, especially with the meconium aspiration, your neonatal ECMO mortality is about 10% or less. Okay? So, to start on ECMO, you need to go to mortality of 40%. You know, if the mortality is 20% on a conventional therapy, you may have to consider ECMO on that patient. So, any patient with the OI of more than 25, we have to consider ECMO in the especially in our centers. So what we say is our unit or NICU, the OI is more 25, they are transferred to us for a possible ECMO there. Again, you got to think about what to do in your own center and just send it up there. We'll talk about the neonatal respiratory failure a little bit later there. So ECMO shouldn't be last ditch effort. We talked about that. And an early initiation seems to have a better effect definitely in a large centers. Okay, and we need to have a coordination of regional ECMO centers with the peripheral referral places when to refer these patients. Again, that's really important there. I will talk about the serious tomorrow, so we'll skip it. Acute life-threatening, potentially reversible conditions. A gradient is not about 60, about 50. We use it for a possible ECMO in a pediatric rather than in a neonate where it's 650 there. Again, oxygen index about more than 40. PF ratio less than 100. But if a single lung disease, single organ disease, with no other organ disease, and if there is no air leaks, especially interstitial emphysema, we actually wait for a long period. So that's another thing. But if there is an interstitial emphysema, we will consider ECMO early because creating more barotrauma there. This kid actually was at H1N1 2009. He came for ECMO after 1 week from peripheral hospital. We went almost on ECMO twice, and ultimately this kid came out, stayed in the ICU for a long time, but came out without ECMO normal. So this other criteria on top of it. So pre-ECMO duration nowadays actually up to 14 days seems to be okay. It's another one there. But what Sunil was talking about, it's how much pressure they are using. So if somebody is using 14 days of a low pressure ventilation, last 1 day they're having a high pressure because of air leak, I would put on ECMO. Whereas 5-6 days of barotrauma and putting a PIP of 50 or something like that, I would rethink before putting an ECMO there. So this is kind of important thing. More and more children are being placed where previously were considered contraindications. Now the largest number of ECMO is the other criteria and pediatric there. So the immunodeficiency, chronic lung disease, BPD patients, when they come up 9 months, they got a RSV infection, we place an ECMO. Somebody with cancers who are not actively on chemotherapy, sometimes we place. This is a patient we talk to the other centers and then maybe we'll play based on an individual patient. I'm going to skip this one. So just one quick thing about the cardiac failure or other rare condition or uncommon condition is the poisonings causing cardiac failure. Beta blocker poisoning, calcium channel blockers, where if you are not being able to manage cardiac output with calcium and glucagon, is not an indication where it's a 100% better outcome in this patient if you put it right place. Contraindications, there are few absolute contraindications. Again, for a new centers, you set up certain things. If they're active breathing, you want to do it, so think about how to do that. So one thing is, what we do is, if in doubt, considering condition of ECMO, we reevaluate. If suppose there is a possible potential neurological injury is there, a newborn is there, so we don't know where is the definite bad outcome is there. So we talk to the family, and then we discuss among ourselves. The family agrees, we place an ECMO, and then we reevaluate. And if you see that the outcome is not going to be bad, or there's it's going to be irreversible condition, then we'll talk to them and then we'll come out with it. So if you don't have enough time to establish a diagnosis of irreversibility,